Welcome to the deep dive. Today we're tackling a really significant topic, antidepressant medications. We've got some pretty detailed source material here, looking deep into the clinical pharmacology, basically, the how and why these drugs work. And our mission, as always, is to take this complex source, cut through the jargon, and really pull out what's essential for you to understand. What are the different kinds? How do they actually function? What are the key things to, keep in mind?
Exactly. And this source is quite academic, focusing on the mechanisms of action, the classifications. It's the foundation for how these drugs are used. We'll try to translate that.
Okay, let's dive in then. To really get how the drugs work, we probably need to start with what's happening in the brain first. According to our source material, major depressive disorder depression isn't just feeling blue. It's described as a clinical condition. You've got things like persistent low mood, losing interest in things you used to enjoy.
Right, and it often comes with other changes, like sleep problems too much or too little, feeling worthless, trouble concentrating, even recurrent thoughts about suicide in severe cases. Now, the main theory the source discusses, the one underpinning most medication strategies, is called the biogenic amine hypothesis.
Okay.
The basic idea is that mood disorders like depression might stem from, let's say, abnormalities in how certain brain chemicals communicate. Specifically, serotonin, often called 5-HT, norepinephrine, or NE, and dopamine, DA.
So these are the messengers.
Precisely. Think of them carrying signals between nerve cells. The source mentions, for example, that serotonin pathways run through brain areas crucial for mood regulation. If that signaling is off, it could affect how we process emotions.
And norepinephrine and dopamine.
They're also key players involved in areas linked to things like alertness, motivation, pleasure, and reward. Also really important for mood.
Okay, now here's a really fascinating point from the source. It says that all the different types of antidepressants, even though they look different chemically, seem to back up this hypothesis because they all end up increasing the activity of serotonin, norepinephrine, or dopamine. Sometimes just one, sometimes a combination.
That's the common thread. They work by essentially boosting the levels of these neurotransmitters in the synapse, that little gap between nerve cells where the signaling happens.
Right.
And this is a really crucial point, the source stresses, even though the chemical levels go up almost immediately after taking the drug,
Yeah.
the actual feeling better, the therapeutic effect, it's delayed. Usually takes about 2 to 4 weeks to really kick in.
Okay, wait. Why the delay? If the chemicals are boosted right away, shouldn't you feel better right away? That seems weird.
It does seem counterintuitive, yeah. But the brain's complex. It has feedback loops. So when you suddenly increase these chemicals in the synapse, the nerve cells that release them have these sensors called autoreceptors. Think of them like thermostats. Initially, these autoreceptors sense the increased levels and signal the cell to sort of slow down its firing, put the brakes on.
Ah.
But over those few weeks, with continued drug exposure, these autoreceptors become less sensitive. They downregulate, is the technical term from the source. As those brakes become less effective, the neuron's overall firing rate actually increases, leading to more sustained neurotransmitter release and signaling. That adaptation seems to be what correlates with feeling better.
I see. So it's the brain adjusting to the drug, not just the drug's immediate effect. That makes more sense.
Exactly. It's a slower adaptive process.
All right, so the source then groups these drugs based on how they boost those chemicals. The first big category mentioned is the amine reuptake inhibitors. It sounds like they stop the brain from taking the messengers back.
That's pretty much it. This group includes several types. The older ones, tricyclic antidepressants, or TCAs, and the more commonly used ones today. SSRIs, selective serotonin reuptake inhibitors, SNRI serotonin and norepinephrine reuptake inhibitors, and also NRIs, which focus just on norepinephrine.
Before we get into the types, though, you mentioned something important earlier, a warning.
Yes, absolutely critical. The source highlights a significant FDA warning that applies across the board to antidepressants. There's an increased risk of suicidal thoughts and behavior in children, adolescents, and young adults, specifically mentioned as ages 18 to 24.
Wow, okay.
It means anyone in that age group starting these medications needs really close monitoring by their doctor, especially early on, or if the dose changes. It's a serious consideration, the source emphasizes.
Definitely something to be aware of. Okay, so let's start with those older ones, the tricyclics, the TCAs. Examples and how they work.
Sure. Think of drugs like amitriptyline or imipramine. These were among the first effective antidepressants. They work, as the name suggests, by blocking the reuptake pumps for both norepinephrine and serotonin.
So more of both chemicals hang around in the synapse.
Exactly. Increases their concentration immediately. But again, you still have that 2 to 4 week delay for the therapeutic effect because of that brain adaptation, the autoreceptor downregulation we talked about.
Got it. But you said they're older. Why aren't they always the first choice now?
Well, the main reason, as the source details, is their side effect profile. They're not very selective. Besides blocking NE and serotonin reuptake, they also block other receptors in the brain and body muscarinic receptors, alpha-1 adrenergic receptors, histamine H1 receptors, which
Wow.
means a lot of potential side effects. Dry mouth, blurred vision, constipation, difficulty urinating, that's the muscarinic block, dizziness when standing up, orthostatic hypotension, that's the alpha-1 block, and significant sedation or drowsiness, that's the H1 block. Plus, weight gain is common.
Okay, that sounds like a lot to deal with.
It can be. And a really big concern highlighted in the source is overdose risk. TCAs can be quite dangerous if someone takes too much, potentially causing serious heart rhythm problems, seizures. They also have a lot of drug interactions. Especially dangerous is combining them with MAOIs, we'll get to those later, that can cause a fatal reaction called serotonin syndrome.
Right. Definitely sounds less targeted. So that brings us to the SSRIs, these selective serotonin reuptake inhibitors. Much more common now, right? Like fluoxetine, sertraline. How are they different?
Exactly. Drugs like fluoxetine, citalopram, sertraline are very common. The key word is selective. They primarily block the reuptake of serotonin only. They don't significantly hit those other receptors, muscarinic, adrenergic, histamic, like the TCAs do.
Oh, so more targeted.
Much more targeted. The mechanism for feeling better is the same. Boosting serotonin leads to that delayed adaptation over 2 to 4 weeks. But because they're more selective,
Fewer side effects.
generally, yes. The source points out much less sedation. In fact, they can be activating so often taken in the morning. Fewer of those anticholinergic effects like dry mouth, blurry vision, fewer cardiovascular issues.
But they still have some side effects.
Oh, definitely. They're not side effect free. Common ones, especially early on, can include things like nervousness, dizziness, insomnia, though these often improve. A notable one mentioned is sexual dysfunction, things like decreased libido, difficulty with orgasm, sometimes even priapism in males, which can unfortunately lead people to stop taking them.
Okay.
And there are still critical warnings. The source strongly emphasizes do not use SSRIs with MAOIs.
Yeah.
Same risk of potentially fatal serotonin syndrome as with TCAs. And also, you can't just stop SSRIs abruptly. You need to taper off slowly to avoid withdrawal symptoms, which the source says can feel like the flu.
Okay, so still need careful management. But overall, why are they often the first-line treatment now?
Based on the source material, it boils down to this. They're generally just as effective as the older TCAs for treating depression, but they have a significantly better side effect profile for most people, and crucially, they are much, much safer in overdose. They very rarely cause those life-threatening heart problems or seizures seen with TCA overdose.
Makes sense, safer, and often better tolerated. What else are they used for, according to the source?
Besides being a first line for depression, the source lists them for obsessive-compulsive disorder. OCD, fluoxetine, and fluvoxamine are mentioned. Some eating disorders like bulimia, fluoxetine again, panic disorder, and even premenstrual dysphoric disorder, or PMDD.
Okay, a broad range. Now, what about the SNRIs, serotonin norepinephrine reuptake inhibitors, like duloxetine? How do they fit in?
Right. Duloxetine, venlafaxine are examples. As the name tells you, they block the reuptake of both serotonin and norepinephrine like the TCAs did.
So are they like TCAs then?
Not quite. The key difference the source points out is that, unlike TCAs, these newer SNRIs generally don't significantly block those other muscarinic, adrenergic, or histamine receptors. They're much cleaner in that respect.
Ah, so they target serotonin and norepinephrine reuptake, but without all the other baggage.
Pretty much. Which means their side effect profile, according to the source, tends to look more like the SSRIs, fewer autonomic, sedative, or cardiovascular problems compared to TCAs. The side effects listed are often similar to SSRIs.
And what are they used for?
Also, for depression and the source notes, they can be effective even when an SSRI hasn't worked sufficiently. But because they hit both serotonin and norepinephrine, they're also useful for other conditions like generalized anxiety disorder, duloxetine is mentioned, and importantly, for certain types of chronic pain, especially nerve pain like diabetic peripheral neuropathy or fibromyalgia, duloxetine is specifically highlighted for those.
Interesting. The source also mentioned NRIs briefly,
Yeah.
just norepinephrine.
Yeah, norepinephrine reuptake inhibitors. Maproteline is given as an example, less commonly used now compared to SSRIs or SNRIs, but targets that specific neurotransmitter.
Okay, so that covers the main reuptake inhibitors. Then the source mentions another group, kind of a mixed bag multi-action drugs, or sometimes called atypical antidepressants. Who's in this group? Let's start with bupropion.
Right. This category includes bupropion, mirtazapine, trazodone, nefazodone. Bupropion is quite different. The source describes its mechanism as a weak inhibitor of dopamine and norepinephrine reuptake. It also acts as an antagonist at nicotinic acetylcholine receptors, the receptors nicotine binds to.
Okay, so different mechanism. How does that translate to effects and side effects?
Its profile is pretty unique. The source highlights very few anticholinergic effects, very little sedation. It can actually be activating, similar to SSRIs. And importantly, it rarely causes the sexual side effects seen with SSRIs. That's a big plus for some people.
What are the downsides then?
The main ones mentioned are potential agitation or insomnia. And a significant point the source makes is that bupropion carries a higher risk of seizures compared to many other antidepressants, especially at higher doses or in people who might already be prone to seizures.
And uses beyond depression.
Yes, interestingly, because of its effects, particularly maybe the dopamine and nicotinic actions, it's also licensed as an aid to quit smoking. And it's sometimes used in combination with another drug, naltrexone, for weight management.
Huh. Versatile. Okay. What about mirtazapine? How does that one work?
Mirtazapine's mechanism is different again. Instead of blocking reuptake, the source explains it primarily blocks specific receptors on the nerve terminals themselves, specifically alpha-2 adrenergic autoreceptors. Blocking these acts like releasing a brake,
Okay.
which leads to an increase in the release of both norepinephrine and serotonin. It also blocks a certain type of serotonin receptor called 5-HT2A.
And its side effects.
The big ones listed in the source are sedation, often quite significant, and weight gain. Sometimes these can actually be used therapeutically if someone's depression involves severe insomnia or loss of appetite. Other potential issues mentioned are elevated liver enzymes and, rarely, a serious blood condition called a granulocytosis.
Primarily used for depression.
Yes, mainly for depression.
Okay. And the last two in this group, trazodone and nefazodone.
Right. According to the source, they share some similarities. Both are described as inhibiting biogenic amine reuptake, though maybe weakly, and both also block that 5-HT2A serotonin receptor, like mirtazapine.
Differences between them.
Trazodone is noted as being more selective for serotonin reuptake, and critically, it's a very potent blocker of the H1 histamine receptor.
Like the TCAs, meaning?
Meaning it's very sedating, extremely sedating. In fact, the source highlights that trazodone is often used at lower doses, specifically for insomnia, rather than primarily as an antidepressant because of this strong sedative effect.
Gotcha. Any major warnings for trazodone?
Yes, a specific one mentioned is the risk of priapism, a painful, prolonged erection, which is a medical emergency and can potentially lead to impotence if not treated. Nefazodone, the source notes, is more selective for norepinephrine reuptake and less sedating than trazodone, but its use has become limited due to concerns about liver toxicity.
Okay, quite a diverse group, those atypicals.
Yeah.
Now, finally, the source talks about a class often considered a last option, the monoamine oxidase inhibitors, or MAOIs. What exactly are MAOs and how do these drugs work?
Okay, so MAOs, monoamine oxidases, are enzymes found naturally in our body, including the brain. Their job is basically cleanup duty. They break down neurotransmitters like norepinephrine, dopamine, and serotonin after they've done their job.
So they reduce the levels.
Exactly. MAOIs, the drugs, work by inhibiting these enzymes, blocking the cleanup crew. This prevents the breakdown of the neurotransmitters, causing their levels to increase in the brain.
Simple enough concept. Are there different types?
Yes, the source mentions there are two main types of MAO enzyme, MAOA and MAOB. MAOA preferentially breaks down serotonin and also NE and DA, while MAOB focuses more on dopamine. Then you have different MAOIs. Some older ones, like phenelzine, are irreversible and non-selective. They block both A and B permanently until the body makes a new enzyme. Then there are newer ones, like moclobemide, which reversibly blocks MAOA, and selegiline, which at low doses selectively blocks MAOB, used for Parkinson's, but at higher doses delivered via a transdermal patch, it loses selectivity and inhibits both and is approved for depression.
And the effect? Still that delayed response.
Yep, same story. The source explains that inhibiting MAOA in particular leads to a significant increase in serotonin levels. This, over about 3-4 weeks, causes that now familiar downregulation of autoreceptors, leading to increased neuron firing and the delayed therapeutic effect.
Okay, so they work. Why are they often described as a last option then? What's the catch?
The catch, and it's a big one according to the source, is interactions. They have numerous, potentially very serious interactions with other drugs and also with certain foods.
Ah, right. The famous cheese reaction. I've heard of that. What is it exactly, based on the source?
The cheese reaction is the classic food interaction issue, especially with the older non-selective MAOIs or those that inhibit MAOA. Here's the deal. Many aged, fermented, or cured foods, things like aged cheeses, red wine, salami, sauerkraut, even broad bean pods contain high levels of a substance called tyramine.
Okay.
Normally, the MAOA enzyme in your gut lining and liver breaks down tyramine from your diet before it gets into your bloodstream. But if you're taking an MAOI that inhibits MAOA,
The tyramine doesn't get broken down.
exactly, it gets absorbed, enters your circulation, and acts like an adrenaline-like substance. It causes a massive release of stored norepinephrine from nerve endings throughout your body. The result: a sudden, severe spike in blood pressure, a hypertensive crisis, headache, sweating, racing heart, potentially stroke, or even death. It's extremely dangerous.
Wow. So you need a really strict diet.
Absolutely mandatory with many MAOIs. That's a major reason they're less commonly used. Plus, the source reiterates the serious drug interactions. We already mentioned the potentially fatal serotonin syndrome if combined with SSRIs or TCAs.
Right.
This necessitates a washout period. The source emphasizes you typically need to wait at least 2 weeks after stopping an SSRI or TCA before starting an MAOI and vice versa to allow the first drug to clear your system completely. That complexity makes them difficult to manage.
Definitely sounds like something reserved for specific situations.
Sure.
Okay, we have covered a ton of ground here, from the basic chemical ideas about depression all the way through these major classes of drugs, TCAs, SSRIs, SNRIs, atypicals, MAOIs, how they work, their effects, the side effects, the risks. It's clear it's not a simple picture.
Not at all. And what's really striking looking at the source material is how you have all these different pharmacological strategies blocking reuptake, blocking receptors, inhibiting enzymes, but they all converge in that central goal of modulating those key neurotransmitters, serotonin, norepinephrine, dopamine. Yet each path has such a distinct profile of effects and potential problems.
So pulling this together for you listening, understanding these differences is key, right?
Yeah.
Knowing that, say, SSRIs are often first line because they're generally safer and better tolerated than TCAs, but might have sexual side effects. Or that MAOIs require that strict diet because of the cheese reaction. Or that nearly all of them need that slow tapering off. It helps explain why doctors make specific choices and why careful monitoring is so vital.
And it brings up a really interesting point, building on what we discussed. That 2 to 4 week delay, think about that. You start a medication, maybe you get some initial side effects like nausea or dizziness. You have to manage these risks we've talked about, like interactions. And you have to wait, potentially for weeks, just to see if it will even help you feel better. What does that reality, that need for patience and persistence despite the hurdles, tell us about the fundamental challenges we still face in treating complex conditions like depression? What stands out to you about navigating that journey, knowing what we've covered today?
Definitely a lot to think about there. Thanks for joining us on this deep dive.